The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Physician Computer Company. PCC empowers independent pediatricians, streamlining daily operations and improving financial stability. A trusted pediatric partner for 40 years, we offer award-winning support, personalized training, seamless data transitions, and practice analytics. With inclusive pricing, a lively peer community, and a free annual users conference, you can focus on what matters the most, your patients. Explore more at pcc.com. That is pcc.com. Pediatric Executive Development System, or PEDS, is a dynamic, transformative program designed to accelerate the growth and development of the leaders in the field of pediatric entrepreneurship. PEDS takes a hands-on approach to problem solving, addressing real-time situations within your organization. More than a theoretical course, it is a practical platform that accelerates learning. Look at our link on the show notes for more information.
Okay, good afternoon. It's a Tuesday afternoon here in New York. And today we have a very special episode because Dr. Herb Bravo, my partner in crime, is working as a pediatrician. You believe that? And today we have Dr. Sabrina Braham, who's going to take his position. And we're going to talk about, with a great new guest, Dr. Ryan Padrez. And the topic that he's going to speak to us about is meeting kids where they're at, school-based care, and the future of pediatric primary care, which should be a very interesting discussion for the lounge.
I'm so excited about this conversation. Thanks.
Yeah.
I'm so excited for this conversation. Ryan, thanks so much for being with us today.
Thank you. It's really fun to be here, and I appreciate the invitation.
Yeah. Why don't you tell us a little bit about Ryan before we start with the questions?
Thank you. I will. So Ryan Padrez is a pediatrician, clinical associate professor at Stanford's University School of Medicine. Ryan's also medical director at the primary school, a new integrated health and education model that serves low-income children and families in Northern California. He cares for patients and teaches residents and medical students at Gardner Packard Children's Health Center and Lucille Packard Children's Hospital at Stanford. And his scholarly work, community projects, and leadership focus on the intersection and reform of primary care pediatrics and early childhood education to eliminate disparities. Very exciting to talk to you.
Yeah. So Ryan, if I call you Ryan,
Sure, of course.
So you go by first name, right?
Yeah.
We start every show with, so why did you become a pediatrician?
Yeah, I love that question. I, of course, have been asked this a few times, and I have two answers or two thoughts that come to mind most. So I remember when making this decision. In medical school, I loved every rotation. I thought for a moment I was going to be everything from a surgeon to an ER doc to some sort of subspecialist. But so that was good. That means I liked medicine because I liked all the rotations. But I really loved the idea of investing time and work in medicine, wearing more of that preventative health, public health hat, and the idea of investing in children's health and what it pays off for in the long run, just really spoke to me and got me excited and got me more really motivated to apply all the energy that we have to apply in medicine to do the work well. I also really enjoyed the challenge of working with parents. And I remind a lot of the students and residents I teach with that everyone thinks, oh, to be a pediatrician, you have to be so good with kids. And we all know as pediatricians, that's actually not that true. You have to be really good with parents. And
that's so true. Yeah.
And so I've always been someone who's been pretty good with parents and enjoy that sort of moment in whatever setting, whether it's in the hospital or in the clinic room.
I love that. So Ryan, you've done some interesting work earlier in your career. I'd love to hear a little bit more about that and how that shaped your experience.
Sure. It definitely shaped it a great deal. So I exited my undergrad time not as a pre-med. I had not done all the pre-med courses, and I was very interested in health policy and economics. And so I went off to DC and really spent a lot of time delving into our healthcare system, where I learned a lot about our Medicaid and Medicare system and it was a fascinating time, a really fun time for a 20-some-year-old in Washington. But from that experience, I took a couple of things. The first was there were very few clinicians, on-the-ground clinicians, that were engaged in that policy space at that time. So this was in the early 2000s. And I got very inspired to want to be one of those voices. And for the few that were engaged, I thought were making a really profound and important impact on shaping some of the policies. The other thing that I took from that experience is I really enjoyed the multidisciplinary sort of intersection of work. When you bring together stakeholders across the table, I found that's when really good work got done. So for example, I was in DC when Medicare Part D was being passed. So that's the prescription drug benefit. And I, in a very nerdy policy wonk way, got very intimately familiar with how Medicaid programs were responding to that benefit. But what was some of the more powerful moments I remember was when you had pharma and you had CMS, so our Centers for Medicare and Medicaid Services, you had AARP, you had state Medicaid directors, you had academic researchers all at the table talking about, for example, how they were going to form preferred drug lists and what the evidence really needed to be. That's when really good conversations happened. And those stakeholders often wouldn't talk to each other. And in the forums that they did, I found really important. And that's a lesson that I think I take through all the work I try to do in trying to bring together stakeholders that may not necessarily always talk together.
Interesting. It always amazed me as to why should medications be so expensive? You were at those meetings. Why?
That is such a good question. My quick answer to this is a lot of companies make a lot of bets and only a few of them turn out to work.
Yeah.
And they just pay the bills with a couple of drugs for a while.
Correct.
And the laws and the patents and the time it takes to get you to generic costs, I think, are still really long in a way that makes it very price difficult for most medications. I'm still very much bothered by how expensive EpiPens and other things are. These basic medicines still are for kids right now. And those should be well into the cheaper versions of these medicines. And so there's more to unpack there.
EpiPens have been around for ages, for as long as I've been practicing.
Yeah, that's right.
Ages. And it should not be so expensive. But I say it's because they can.
Yeah, that's
Because
right.
they can. There's no other EpiPen. There's the other one, the AviQ. That's really expensive. They got the technology that talks to you, but that's overpriced also. All right.
That's a really good answer. It's because they can. Everything is because of the systems we've created, right? We've allowed, there's no one to blame except ourselves in terms of the policies and rules of how things work.
Even vaccinations. They're coming out with all these vaccines, $200, $300 a dose, and they need 3 doses. For the hepatitis B and the old school vaccines, they're $20. And that's reasonable. But if you lose 1 vial of Gardasil, you lost a lot of money.
Yep.
Yeah.
That's right.
So Ryan, if we can get back to this sort of interdisciplinary conversations, I'm curious if you think there are particular conditions that make that possible to have different silos connect and share information in order to collaborate?
Yeah, it's a good question. I think it comes in some of the lessons learned with this work is, I would say two things that really stick out in my mind. The first is having a shared North Star of what everyone's working towards, and be the obvious thing, but figuring out what that is that we can all sit around the table to work towards is an important first step. And the second step that I think is really critical to making sure the conversations actually go well is really looking out for where there are differences in understandings of terms that everyone's using. And so a really good example is case management or care coordination. And, when you sit at a table and you're talking to social workers versus nurses versus pediatricians versus health plans, everyone has a different shared definition of what that is. And that causes often a lot of breakdown in conversation and confusion. That was just an example of one that I had recently that was an aha moment. And so those times where you're sitting around different disciplines at different trainings, being mindful that we throw around terms often that different folks have different understandings, and that leads down the wrong track sometimes.
Yeah.
Yeah.
So you've been front and center in this bringing together of silos in the education and healthcare space with the primary school. So I'd love for you to tell us a little bit about the vision and mission of the primary school and maybe the origin story.
Sure. Yes. So I've been attempting some of this work for the last 7 years now or so at the primary school. And I guess stepping back to the origin of how it got started is so as many might know, or as they read, the primary school was started by Priscilla Chan and Meredith Liu. And both of them, so Priscilla was a teacher before she became a pediatrician, and we got to know each other well in our training years at University of California, San Francisco, both in medical school and residency. And we would often banter and have conversations in our primary care clinic at San Francisco General Hospital at the time and say, if we just had a school we could communicate with around some of these kids, we really think we could provide better quality care to them or have a better understanding of what we're missing or what's going on here. And so that sort of became a nagging question at Priscilla, at myself. And as she finished up her training, became not just a nagging question, but became a mission to figure out how could we build a new model school that could better collaborate with our healthcare system, with pediatricians, with the pediatric medical home. And so spent a good amount of time looking at models that were doing aspects of this work and came back to some ideas of what it could be. And early on in that process, because she knew I was someone that loved thinking about Medicaid and our systems and how things would be paid for, started slowly roping me into the work. And it was just naturally what I've always been excited about, which is how do we think about new models of care for kids? How do we think about working across sectors? And the real vision of the school is how do we build a new model of a school that can really help all children thrive? And we think that has a lot to do with breaking down the silos that often exist in our sort of systems of support for kids across healthcare, across early education, across K-12. Or another way to say it is, how do we create a school where all the adults that a child may need in their life can work better together? And so we have 2 campuses now. We have one in East Palo Alto here in Northern California. We have another in the East Bay in the Hayward region. And both of them are attempting to build this model school. We say we have 3 big bets, for lack of a better word, that we're placing into this, which is for a school that, let's say an elementary school or middle school, which is what we're striving to build. Our first big bet is starting earlier. So what does the programming in a school look like in preschool and pre-preschool to really ensure all kids enter into our school thriving and ready to learn? The second big bet is on school making an investment in programs that support the parents. And there's a term that's very popular now called 2-generational programming. So not teaching parenting classes, but actually supporting the parents as adults, their own mental wellness, their well-being. And what program could that look like being based out of a school? And then the third is, and how do we build a school model that can better collaborate with our pediatric medical homes, our healthcare system? And what does the school need to put in place? And then what do we need to ask our healthcare partners in the medical homes to do to better work together? And so that's where we're making our sort of investments in design and programming and see. And it's been an incredible learning journey as we build out this school and these programs.
Interesting.
George,
I have
when we
a
were
question.
talking,
Yeah, go ahead.
I was going to say, when we were talking before about this episode, you had a question that I thought was so interesting. What was your question about this school-based healthcare?
But don't the schools already have a school physician or a school nurse or one physician with many schools in their office that stamps out the school forms and lets them play sports?
Yes. Or you could conversely say, aren't there a lot of schools that have school-based health centers? What are you doing that's different? And so I would say, let's start with your first question around, isn't there already the school physician and school nurses? And yes, there are. And we absolutely want to take advantage of that and think about how do we add to those structures and team members, because clearly it's not enough. There's too many children that still aren't thriving in this sort of structure. And so the sort of design conundrum that I've had for the primary school is, like, while there are some amazing school-based health centers, and when I use that term, I'm talking about brick and mortar clinic that's built like adjacent or into a school. that will staff it often with a pediatrician or a nurse practitioner and some folks. There are some amazing school-based health centers out there, some that I am in awe on, and I took a lot of inspiration and think they're doing incredible work. However, we know that many of them are hard to scale up. They're hard to sustain. They're hard to financially keep the doors open or spread to more schools. And so the question that I had was, what can we learn from those high-achieving school-based health centers? And could we think about building some similar programs and systems that leverage the surrounding medical homes around the school instead? And that might mean changing our school-based health team, who is actually on that team in addition to the school nurse, and what other tools and communications and I would say programs that we arm our school-based physician with at that medical home to be able to better care for the kids at the school. So our approach here is we are leveraging the medical homes around our school sites. Primarily, there's a federally qualified health center named Ravenswood Family Health Center. There's a clinic that I work at as part of Stanford. Some of our kids go to Kaiser Permanente as a clinic as well. They're almost all Medicaid insured children. But they all go to their pediatrician for their routine care. The question is, what other services do we bring at the school to help identify and help co-manage any sort of health barrier to learning that we might be picking up at the school to ensure they thrive on campus? And some of those programs and services are very similar to what other high-achieving school-based health centers are doing, and some of them are a little bit different.
And what can you drill down into what that looks like on the ground in terms of your programs?
Sure. I think about it as two buckets. In order to leverage the medical homes that all our kids are going to, whether let's just say a child at Ravenswood Family Health Center, and a need comes up at the school that we identify. First and foremost, we need to ensure that child is already plugged into that medical home, that they have their preventative care done. So they've gone to the annual physical in the last year. So we have a lot of actually programming investment, just making sure all our kids go to their routine preventative healthcare every year.
So making sure they have a primary care doctor and then making sure that they have their annual visits.
That's right. Because if something comes up, it slows us way down to find out that child actually doesn't have a medical home. They haven't seen the doctor in 3 years. And now we're starting for a long time before we can even quickly escalate up to any sort of subspecialty care or anything else that may be needed. So we spend a lot of time at the beginning of the year making sure all our kids get to well-child visits. And that's hard work. And we have good adherence with that. We've got into this conundrum. Is it a stick or a carrot, in terms of, do we require it or do we incentivize it? And we're definitely on the incentivized end of it. And we're really trying to partner with families as to better understanding what the barriers are to getting to that primary care clinic. And there's steps that we can do in terms of scheduling. We even try to find some Saturday times and some others to meet families. But that's step one. Along with that is we have all our families sign the proper release of information at the beginning of the year to overcome HIPAA and FERPA barriers that often make communicating across the school and clinic challenging. So our families are placing a lot of trust in our program, signing the form, saying we give permission to the health team at the primary school to speak to our pediatrician's office, and we give our pediatrician's office the ability to speak. And we try to do this in partnership with the families, but getting that release signed is really helpful at the beginning of the year. So that's step one. Step two is now, what are the programs and services we want to bring into our school that really identify the most, from an epi perspective, the most highest prevalence health barriers to learning? How can we identify and then help address and manage any sort of health barrier to learning that many of our kids are having? And unfortunately, despite years and years of great primary care pediatrics, the most common health barriers to learning are still really prevalent in our population. Vision needs, dental caries, poorly controlled asthma. Those are mental health needs, are probably the four biggest, and they're still been around for many years. The only one we made progress from as a health system is lead. And that was because we invested in some laws and some public health changes, and we really enhanced our screening programs so we changed out paints, we changed out pipes, and enhanced our screening program. And for over the last 20 years, the incidence of lead in schools has gone way down, or in kids in schools. But that's really the only one. All the rest are ripe for innovation of programs of how we can do a better job ensuring those common health barriers to learning aren't missed in kids. And so those are we have programs going in all those areas. And then we have just a routine case management sort of structure as well, because there's all sorts of needs that come up with children. And if it's a need like constipation or a need like migraines or headaches that come up, like that can be really detrimental to a child being able to thrive in school. We have a system where that can be identified. We have a case management meeting with the nurse, and we have a system to communicate back to the pediatrician, get them into their medical home, and start to figure out how we quickly or more quickly address that.
So is a critical piece of this the case management or care coordination or whatever term you want
I
to
think
use?
so. That's right. Which was why I shared that story. Yes. And it's really drilling down on the roles and responsibilities of the school versus the clinic, and how much handholding do we need to be providing versus really trying to help our families build the skills to navigate the system too. It's a balance that we're constantly walking, and lots of lessons learned, and we're figuring it out. But I think the important thing to take away from this conversation is I still think the school setting and school sites is a really critical piece, and think of it like almost like a safety net, like where we can catch all kids that might be having some sort of health need that's there, that at the moment is impairing their function in school. It will soon impair function in other areas too. And I think for too long, we don't catch that until a lot later, when things are potentially a lot worse by the time they come back into our office or they come into the emergency room. And so how can we build some sort of system, some sort of safety net that we can catch a lot of kids quicker and sooner and be able to leverage in the health system a little bit easier?
But aren't these checks and balances already implemented in the schools with the school nurses?
You
You know how
know,
many kids I get? The nurse I had a sore throat. She sent me home. Won't let me come back until I see the doctor. Um,
so it's a great question. And I would say it varies across the country quite dramatically. Unfortunately, here in California, there's a severe shortage of school nurses where, one school nurse for a district or two school nurses for an entire district. And so I would say it's the rare more than the norm to have a regular nurse at the school. And I love our school nurses, and I work a lot with school nurses across the area as well as nationally on the National School Nurse Association, and think they have a new guideline out that's the 21st Century Guide to the School Nursing. And a lot of the tenets that they have in there in that guideline, I think, are spot on to where we should be leveraging our school nurses. And that's a lot more in the population health, thinking about a school entity, less about worrying about the individual like boo or headache for a kid. That can be triaged and sent over to where they need to go. But for a trained clinical RN, how to really get them to be overseeing programs that oversee better asthma control or better diabetes control or things, rather than leveraging that nurse's time to go check one student's sugar, is, I just don't think, a good use of value for that school nurse. And it's where I've been playing around with is, what does the staff structure at a school need to be? Because if school nurses are in short supply, we can't hire very many, or who else
Is
needs
it a
to
workforce issue or a funding issue?
I think a little bit of both.
Yeah.
I think it's both. But if we can't hire enough, who else do we need to be putting in place at the school to support that school nurse? And so that nurse can be operating at the top of his or her pay grade to do the best work, and then triage other sorts of programs and staff to the school-based health team. That could be community health workers that could be paid for by Medicaid dollars if that gets set up correctly. It could be staff that are more trained at like the MA level that are capable of doing a lot of great things for student health, but you don't need to leverage all the time of that one nurse.
So it sounds like one of the big challenges is just scaling up the infrastructure to be able to deliver this kind of care in the school setting.
Yeah.
Am I right about that? And then, so what about the challenges that exist in coordinating with the pediatric medical home?
Yeah.
I'm wondering if you can share some of those.
Yeah, there's, of course, first and foremost, the biggest challenge is it's always about seamless communication, and how do we communicate such that it plugs into our busy pediatric workforce's everyday workflow. If we have to have something where it's a separate message or a separate email or something else going on, that's just very hard to sustain and hard to keep easy. And so and unfortunately, our electronic health records in most of our primary care clinics are very hard to integrate into any sort of school setting. They're very protected. And so until we can overcome that gap, the communication barriers are going to be really challenging. And so we leverage right now our school nurse. So to go back to that role in particular, the way we try to tackle this is our school nurse is part-time at our school and part-time at our most prominent partner clinic, Ravenswood Family Health Center. So she was a nurse there for many years, really saw the opportunity of, if she could work with the school more collaboratively, a model that was a bit more innovative and integrated. And she got very excited about this role, very excited about working with us. And so she's at our school for about 2.5 days a week, and she's at the clinic for 2.5 days a week. And what this has been able to do is bridge not only some of the communication gaps, because she can more easily just plug it right into the EHR messages and things, but there's also the cultural gaps that happen between a school and what they're thinking about in the terms of the school administration leaders around the child's needs versus what a pediatric office needs to hear. And it's been, I think, maybe one of the highest values there is having that shared staffing model between a clinic and a school. So could we all imagine, what if we started to solve some of our school nursing shortages by hiring part-time nurses from some of our clinics that spent a couple days a week over in the schools to be able to follow up on some of our kids' needs, better communicate, figure out better asthma action plans at school and other, I think it could be a fun structure to explore. And I didn't invent this. I got this from, again, some high-performing school-based health centers in Baltimore that were doing this.
That's interesting. George, what's your question to that? I can predict it.
What's my question?
I'm going to predict that your question is, how do we pay for it?
How do you pay for it? Exactly. I was waiting for that.
Was I right? Was I right?
Yeah.
Yeah.
I mean, these things are all great things to do.
How do you pay for it? There is the biggest challenge. Not an easy answer. So the first is, one, I think schools do have budget for school nurses. And even though, right now I think we're underhired. So there is, I think, some opportunity there across to hiring more nurses. And especially if we could get them part-time from clinics as an example, would be very cool. But the two or three funding streams that I see happening for this are, the first is on this education side. There's a big movement of community schools right now. I don't know if folks have heard of that, but there's lots of federal money coming into it and state money coming into supporting community schools, which can mean a lot of different things in different states or areas. But it's the idea that, how do you support the whole child with other programs? A lot of things like food, resources, maybe other social services that you're bringing into a school, but those get staffed up by community school dollars. Hypothetically, I could argue you could staff up more health resources as well, like more staff to support a school nurse with some of those community dollars. So that's one pocket of funds that I think could be explored to do this in public schools and big district schools.
And community school funds are flowing through the educational system.
That's
and
right.
Partially through Medicaid, or completely for the educational budget?
It's all through education right now, but through Medicaid, as I think we were talking a bit about before, there's the Centers for Medicare and Medicaid Services put out a new TA sort of guide, technical assistance guide for schools on where are more dollars available for schools to be billing Medicaid for certain services. And so this is most helpful at districts, bigger districts, because it takes infrastructure to set this up. It's not as helpful, for example, like a small nonprofit private school that the primary school is right now. But there's a lot of opportunity for schools to be billing for more health services, a lot more mental health services. And so if you have more Medicaid dollars coming into the school, perhaps that could go into paying for staff and or nursing support to be able to do bring some of those programs to life.
For pediatrics, Medicaid in general doesn't pay very well for a physician.
That's right.
Doctor's office.
That's right.
You're asking for money to pay for a nurse.
Yeah.
What else?
I'm proposing that there's money left on the table right now that schools are leaving on the table. They're providing a lot of these services. They could be collecting dollars from Medicaid for a lot of the services they're providing. It does require a little bit of infrastructure, a little bit of billing and some things. And this is what this very hefty technical assistance guidance is there, because a lot of schools are like, man, we got so much wrapped up in dealing with the education programs. Like, we can't deal with Medicaid right now and how to bill for these. And so CMS said, okay, we got you. And they came out with a very helpful big document that helps schools set themselves up to be collecting more Medicaid dollars.
So that's a good innovation opportunity, right? To provide the infrastructure to schools to access those funds.
Absolutely.
Yeah.
I think ultimately
business idea for anyone interested.
I think like where this gets paid for at the end of the day is when pediatrics finally starts moving to accountable care. And when we say, okay, we're going to have so much dollars set aside to be paying for a child in a year, and you have an accountable care organization, I think it's going to be extremely wise for whoever is these accountable care organizations to start to think about schools and school settings as a place to make a little bit of an investment.
I'm involved in value-based contracts, accountable care stuff. Pediatrics is volume.
Yep.
But pediatrics is not a lot of volume and money.
That's right.
That's the problem. So to
That- and
spend on a
George,
kid,
can you say more what you mean by that? Volume? You mean
there's
the
a lot of
margins are narrow?
there's a lot of bodies, heads, okay, children. So the pediatric end increases the roster, so the membership of an accountable care organization. So if an organization does well and reduces spend, okay, what will happen at the end of the day, if there's any shared savings, that membership now is really big because there's a whole lot of kids in there. So that per member per month fee will come back to the organization, and there'll be more membership of $5, $8, whatever it is per member per month times 12 months times however many people. There's a lot of money to be made. But unfortunately, in pediatrics, one child with one devastated illness will blow everything up because there's no value. There's no money attached to the kids. That's the problem.
That's right. We could have a whole hour-long episode of why accountable care in pediatrics is not working or set up to be challenging.
Yeah.
And that's because kids just don't cost a lot in our healthcare system.
They don't. Interesting thing is, if you go, because a lot of these companies are going into quality first and then shared savings second. So if you do good quality and you do shared savings, you hit a home run. If you do good quality, which I promise you, all pediatric offices do good quality, and you miss on the shared savings, you missed on everything.
Yep. And the conundrum that I have in my head is when I'm talking about who are these programs going to best set up to serve, if we're really leveraging schools and school settings, it's all the kids that are not touching our healthcare system very well.
Yes.
And that's not where there's any savings. So in fact, if you had more programs in schools that were identifying more kids, you're not cost savings, you're costing more. You're billing more for time for subspecialty care that never made it to a subspecialist, who wouldn't have made it to a subspecialist until they're an adult, and then that problem costs a lot of money. But that's not the way our healthcare system is set up. And this is a big challenge pediatric has. But I'm going to keep my optimistic pediatric hat on and say, I'm still going to go after a good quality. And what are the good quality programs that we could be building? And this is why I still think school settings provide a really high value opportunity. One other cost area just to build is telehealth in schools. So I do think there are, if you can set up the infrastructure to bill for that time on the telehealth side, there's some opportunity there as well. I see it less about the billing opportunity and more the convenience and easier access for a lot of families to have to their medical home. And so if you could set up some telehealth portals at schools to be able to do that, I think that could be a real help for a lot of families that just getting over to that medical home in between work schedules and everything else that needs to happen is sometimes really hard.
Yeah, and it maintains continuity of education too, right? You get butts in seats. They're not missing class. They're not missing days of school. Parents aren't missing work.
And so a lot of schools are paying for these telehealth programs in schools by their ADA, so their average daily attendance. So schools get paid by kids in seats in school. If you have a program that increases attendance, similar to the way you described accountable care, that $5 or $8 savings, well, multiply that by 10,000 kids, that's a lot of money on a daily basis that schools can save. And if telehealth programs help to do, that's how some of them are contracted and paid for right now. But so it's all, and this comes back to what I'm sure you've talked about many times on this show, the wrong pocket problem. Like a lot of these programs that I'm talking about in the short term are going to help schools. They're going to help kids stay in school so their attendance goes up. Maybe if I have a program that's helping asthma, perhaps their test scores go up. Perhaps their graduation rates go up. All the things, the metrics that schools care about. It's not going to help the healthcare system much, except that maybe you might avoid an ER visit. That, like you said, it's just not that much savings.
Yeah.
So can you help us understand this concept of high value care a little bit more and how that relates to school-based care?
Sure. It's all about, it's how we describe high value care in some of the quadruple aims now that we're talking about with it. And I put high value care, that fourth aim of equity, to be really important here in terms of where I think the value of school-based programs add to the equation of high value care.
Maybe can we just back it up for a second? Just
Sure.
let's define high value care and then just define like the quintuple aim, just so everyone is on the same page.
Sure. So adding to the triple aim of, in terms of care that is lowering cost, increasing your quality of your outcome, and doing it for, I forget what the third aim is of the triple aim.
Yeah, I think it's costs, quality, and outcomes. Or
Yep.
and then the last two are equity and physician wellness, right?
Sure. Yeah.
Triple Aim's focus is improving patient experience, reducing per capita cost of healthcare, and improving the health of populations overall.
Yeah.
Thank you. Yes.
Thank you. So then physician wellness and thinking around equity issues is where I feel like school health really adds to this equation. And so I've already talked a little bit about, from a physician wellness perspective, as we all know as primary care pediatricians, those having the ability to talk to a school in a more seamless way, have communication lines back and forth, I know what contributes to my wellness is when I can talk to schools a little more easily. And I know it contributes to a lot of my colleagues who say, oh, this has been great to have this communication lines open around this child. It's helped ease a lot of stress. So I think there's a there for that. And then in terms of, though, back to the equity issue that I think a lot about is, who are all the kids that aren't getting into the doctor, that we're not best serving? They're all still going to school. They're all at school. And that is, we have birth to 5. It's all pediatricians. All kids are in our healthcare system. They're all coming in for their well child visits. And then once you hit that 3, 4, 5 years old, there's many kids that fall off in terms of adhering to that regular visits, but they're all going to school. And so I still think this is the ultimate safety net of where we can catch all kids. And how do we build the programs and connections to our healthcare infrastructure to ensure all kids are getting high quality care? And so that's where I feel like the school partnership work could help.
What about how we think about collaboration as pediatricians? So have you encountered resistance from pediatricians? I'm curious actually if that's true, and if that maybe is different depending on the population that you're serving and the resources of the clinic.
Sure. Yeah. We've had moments of resistance, and it's all about time and what the ask is of that pediatrician. In terms of, there's been moments where it'd been great if they joined a school-based meeting that we had. But of course, the time for that is not there. Could you Zoom in? Could you send in a few statements about it? So finding that's just not feasible for a panel of hundreds or thousands of kids that they have to be doing. So the resistance there is, I think, initially, for the sake of this trial or this pilot or this innovative idea, could you try this? But they immediately, a lot of brains go, but this is not scalable for all my kids. So no. And I get that. And I understand where it is. Some of the other lessons learned on resistance that I've had is, we all just bemoan school forms. You mentioned it before, stamp the school form and get them there. And so I also just despise school forms and wanted to come up with a more simple school form for our kids at the primary school. And so I developed my own form that I thought was going to be really simple for a pediatrician to do. And I got so much pushback that, oh, now you have your own special school form. No, like you need to have the standard form. That's the only one I'll possibly think about filling out, not a separate form, which was a good lesson learned. It's all about, everyone is busy. Their schedules are packed. They're spending probably way too much time charting afterwards and following up with their patients. We can't make more asks in any of those areas. We have to think about ways to make this easier on physician time.
Yeah, but there's also the medical legal aspect of it, right? So I'm busy in my office. Somebody's going to call me asking me to make a medical decision on somebody that I didn't see.
Absolutely.
That's where you're going to have a problem. Send them to my office. I'll make a decision.
Yep.
But you don't want that.
No, absolutely. And yeah, you don't want to set that up. You want to be collaborating with whoever is seeing the child. That's right. Yeah. And whoever their medical home is. But we know that at a lot of community FQHCs, I share a panel with 20 I cross share lots of patients. And so maybe I'll see a kid or my colleague will see them the next time. And there's a pediatric family that might be seeing multiple pediatricians might be seeing a child.
Mhm.
And that's where the telehealth and the school nurse comes in, right? Because they can be an extension of that, of the clinical piece, right?
Yeah, that's the hope. The hope is to try to get better continuity of care for more of our kids.
Yeah, I was challenged with one of these private schools. The hospital system wanted to develop a telehealth school thing, right? So the idea was, if the nurse has a kid that has a problem, could she beam into our office and we can examine with the nurse? She'll tell us the story
Mhm.
and decide what to do with him. Basically, send him home or keep him there and do the following. It was a great idea. You had the nurse that was involved. You had the office that I committed to. I always say yes, that's Sabrina. We'll do
I
it.
like that.
And it never. It ended up in politics, and the politics killed it. What can I tell you? The medicine was there, but the politics got in the way, and the legalities got in the way, and the lawyers got in the way, and administrators got. No, we had the administrator on our side. So back to status quo.
So Ryan, what do you think needs to happen for school-based care to really get a foothold?
To take off.
Yeah.
I think so. I right away, one of them is what you just mentioned is we got to get the lawyers out of the way in a way.
That's not very nice to the lawyers.
I know.
They mess things up.
I love lawyers, except for when they get in trying to be too protective. I like, for example, EHRs in terms of electronic health records. This is not a technology problem. This is a leadership and lawyer problem. They could easily communicate across to school settings. And I would say the Children's Hospital of Orange County, CHOC, that hospital, there's some really cool innovations going on of sharing out data from their EHR to the school district. And there's some just cool innovation stuff happening there, which shows this is possible. And
how did they overcome the barriers?
It's a great question. They very slowly and painfully, is what I've heard. It's helpful for them because they have a monopoly. I would say that's not probably the right word, but they have a lot of primary care clinics attached to that hospital. And so there's probably one EHR system that can touch many schools. And so right now, when you have a whole gamut of different EHRs, it makes it more challenging when it's 20 different ones. But I really believe we got to think about a way to make data sharing easier between schools and healthcare and do it in a way that's still patient protective, but still enabling better communication. So on the flip side, that also might mean sharing data from the school to the doctor's office. And so a really, I think, tangible example of this that I would love to see take off more is attendance and attendance data to our pediatricians. I think it's the missing vital sign that we're not collecting on most of our kids. How is their school attendance this year, and how many days have you missed in the last few months? And that could be shared with the right sort of leadership to pediatricians' office in a way that could be extremely helpful. And there are some people pushing the envelope on this in Washington, D.C. There's some really cool work going on of the school districts preparing attendance reports that are being shared to pediatricians' offices so that they can then quickly identify and address it. So data sharing, big one that needs to happen. The second one we've already talked about is payment. There just needs to be, this is not a really expensive problem, but this is one that could provide a lot of high value to many kids with just some more staffing that could be provided on the school sites to help schools do this. That I would love to be affiliated with the medical home so that we're not creating, again, a siloed system. Where I thought you were going to go with your telehealth story, George, was where I found a lot of them is, okay, a telehealth company comes in and they're great and they see the child maybe with some remote doc that steps in and sees the kid. And then they create a report that then needs to get sent to the medical home. And you're creating just yet another siloed step of, I never got the communication. They showed up in my office. I have no idea what happened. And so I think if we keep going down that line of thinking, we're just creating more silos and more fragments. We need to think about, where does infrastructure from our pediatric medical homes go out into the schools? Where's there an extension of it? And this is what I've been having a really fun time collaborating with Kaiser Permanente, who's our healthcare partner in our East Bay site. And it's just a preschool right now. It's a small site. But most of our kids go to a Kaiser Permanente clinic. And that's the design question. How can we have a preschool site, early education site that can be an extension of that Kaiser Permanente medical home? And so telehealth and other visits and staffing that they can be bringing over to our school site on a very part-time basis to address some issues has been a really high value way to explore that partnership.
And how are you guys solving the data sharing problem?
Not easily.
Are you using fax machines is what I want to know.
Oh, thank goodness no. But I'm still faxing a lot out of my primary care pediatric office right now, all sorts of places. No, we have an electronic health record at our school, and that's a school-based technology that we use. And by having that shared staff of a nurse and some others, they generate reports that then they go type into their EHR. So it's not, I wish it was seamless. I wish it was something better. It's the same at Kaiser as well, in the sense of they have to upload the right information into their EHR one-on-one basis. But what we're trying to get to is making sure we can really distill down to the most high-value communication that needs to happen. And it's not novels and novels of things that need to be communicated.
Amen to that.
Yeah.
Amen. So we're coming up on the hour. Maybe I'll just ask one last question to squeeze out the last bit of knowledge. So what innovations are you most excited to see in the next 10 years that could truly transform child health outcomes?
Good question. I really believe that data sharing is going to happen in the next 10 years in some form. And it might be more data sharing in the hands of parents or families around a child and giving them more control. I think with cloud-based technology now, this is not a technology problem. It's all there. This is a leadership and for lack of a better word, a lawyer problem that needs to be overcome in order to help make our work as pediatricians, help make the schools work as educators, and help make parents work as caregivers easier to be able to make that happen. And I just think there's going to be more and more tools to be able to do that. I think that, and I am excited, if we're talking about school-based health sites, I think that tools like telehealth, tools like innovative staffing models, different payment structures to incentivize quality around some of this are going to accelerate, I think, some cool innovations in this space. Similar to how social determinants over the last 20 years took off, of people recognizing that there's actually a lot more that drives health outcomes besides just the medicine. In pediatrics, I think we're just on the cusp of, wow, there's a lot more that goes into a whole healthy child than just the shots and the well-child visit. There's what else is going on, and schools, I think, are going to be a really important partner in that.
Yeah.
I love that. Thank you so much. It's been amazing to talk to you today.
Thank you very much. Thank you.
It's been a pleasure. I love your questions. Thanks so much for having me.
All right.
Thanks. Bye, guys.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.